Good afternoon, everybody. Here we are, Zooming our way through social distancing. My name is Peter Werwine. I am Senior Editor at Managed Healthcare Executive. And with me is Meg Murray. She's a member of our editorial advisory board, but that's kind of the least of it. She's founding CEO of the Association for Community Affiliated Plans. She has led the group since its beginning in 2001. The ACAP, as it's called, it has 74 safety net health plans as its members, and those plans cover a total of 20 million people in Medicaid, Medicare, and ACA marketplace coverage. Meg is also a national expert on healthcare coverage and policy for people with low income. She received her MPA from the Woodward Wilson School at Princeton and is a graduate from Wellesley College in Wellesley, Mass. So Meg, thanks for joining us.
Happy to be here. This is my first Zoom interview, so it feels very modern, and I appreciate your taking the time to talk to me about these issues.
There's a first time for everything, and I think for many of us, this is the first time doing Zoom interviews. So I guess just to start, why don't you just talk about your organization a little bit, and maybe there's why it formed, and maybe some of the more prominent members, the names that people might recognize?
Sure. Well, this is actually our 20th anniversary year. You can see from my background that we are celebrating it. Had intended and still intend to celebrate it publicly this year, but we'll see how that evolves. We were set up about 20 years ago by 14 health plans that were owned by community health centers. And some of them that a lot of people know are Neighborhood Health Plan in Mass, Neighborhood Health Plan in Rhode Island, Aloha Care, Care Oregon. And over time, we have been evolved so that now we represent Medicaid plans that are nonprofit or are owned by nonprofits and focused on the low-income programs. All of our members serve Medicaid clients, and about half also serve dual eligibles in Medicare in some fashion, and about a quarter also serve people in the marketplaces. So some of the other plans that a lot of people know, in addition to the ones I mentioned, our chairman runs Commonwealth Care Alliance in Boston, which serves primarily MLTSS eligibles. Community Health Plan of Washington in Seattle, our vice chair is Leanne Burge, and she runs that plan, which is also a founding plan. So those are some of the plans that are a little bit more well-known. AmeriHealth Caritas is also a member, and so is CareSource, which are some of the larger ones. Typically, our plans are just in one state, but AmeriHealth Caritas and CareSource are in multiple states.
Good, good. I think that sort of situates people and who we're talking to today. So we are talking amid the COVID-19 outbreak, and of course the world is coping with it, and maybe particularly the healthcare sector. In terms of how insurers have responded, the headlines have been dominated by the waiving of cost sharing. Initially, it was just for testing, and then the large insurers moved on to waiving cost sharing for actual care. So I'm just wondering whether your members have done something similar, or maybe cost sharing wasn't such a feature of the coverage for these plans, but what has been sort of the response in terms of coverage and cost sharing for your group?
Well, many people are surprised to learn that Medicaid does impose cost sharing, both co-pays and co-insurance. And in fact, I think there's 16 plans that impose some type of co-payment on, 16 states that impose some type of cost sharing on hospitalization. Sometimes pretty significant, up to $140 a day in Arkansas.
Wow.
And so our plans then oftentimes are the contracts require them to impose co-pays, although they can choose not to. But so as this COVID pandemic was unfolding, our plans were very seriously talking about this. Immediately, we said that we would not impose any co-pays on testing. Later, that became the law, but we were out in front of that. And then similarly, on the treatment, our plans have come out and made a commitment that they will waive co-pays, deductibles, co-insurance, all of that for the treatment of COVID as well. And then in addition, they went a little bit further. They also said that they would waive prior authorization for anything related to the treatment and diagnosis of COVID. And then they went even further and they said that they would waive early medication refill limits on prescriptions. And of course, also they are at least to the extent allowed by law, and even further encouraging and supporting telehealth. So those are some of the things that our plans have come out very publicly in support of in terms of addressing this. And then there's things that they are doing which are required by law, but just we wanted to be explicit about it too, so that people know and this applies to the Medicaid and Medicare lines of business, that they do cover all the testing as is required by law. They're waiving the testing, as I mentioned, for co-pays, and that they cover all treatment for all COVID-related illnesses. So, so our plans really have been out there in the forefront of this, and I know some of the bigger plans have said it too, but this is the safety net plans coming out last week very explicitly and making this important commitment.
So, is there any information or data yet, even, I guess anecdote is not data, but about how many people in your plans are being tested and how many have been treated, and therefore how many have benefited from the waiving, financially anyway, benefited from the waiving of the out-of-pocket costs?
It's really too early to say. Providers oftentimes don't get claims in for 30 days. And, as we know, the epidemic has certainly been here since January. We know that, but our plans are just seeing that. So it's going to be a little bit of time before we see the claims, but we are very concerned about the impact. Since the plans are making this commitment, they're saying it's waiving the co-payments for the beneficiary, but it's the providers who typically collected that. And so the providers are being made whole, and our plans are taking on that expense of the co-pays, which was not included in the rates. And then, of course, the underlying payment that we need to do for the treatment. So one of the things that we are very concerned about is just the impact on our plans. And as I said, we clearly don't know what that is yet, but we were glad to see that the Medicaid rates Medicare Advantage rates that just came out this week are healthy and will hopefully support things going forward as these things unfold in 21. We would like to see risk corridors, though, in Medicare Advantage Part C, just so that which was included in the House bill for COVID-3, as we call it. So we'd like to see that included if and when there's a COVID-4 to protect our plans that are doing the right thing and treating these folks. We'd also similarly like to see some type of reinsurance or risk corridors reestablished for the marketplace for the qualified health plans, because our QHPs are also taking on treatment costs that they did not necessarily expect. And then for Medicaid, which is the bulk of our business, we want to make sure that plans, that the states continue to preserve actuarial soundness. And some states are starting to ask for waivers of actuarial soundness, which is very concerning to us, because our plans have reserve requirements that the states impose. If they end up if they're putting out more than they're getting in premiums, they may be out of compliance with the reserve requirements. So there's a very, big concern that the rates need to be actuarially sound for Medicaid. So those are the three things that, we don't know what the impact's going to be. And certainly there are lots of elective surgeries that are not happening right now. But we also know that these are, when we say elective surgeries, it doesn't mean, cosmetic surgery necessarily. It's things like breast cancer surgeries that are being put off, and other things that are going to happen one way or the other. It's just a matter of when. So, so those are the three things that we'd like to see the federal government enforce actuarial soundness, and then allow and fund some type of reinsurance or risk corridors in both Medicare Advantage as well as the marketplace.
And how would actuarial soundness be funded precisely? What's the mechanism?
Well, right now in the contracts that are set and the rates that are set are based on the state agrees that the rates and the plans when they sign the contracts agree that these are actuarially sound rates. And so the issue is that going forward for the next contract period, would they still be at the level that's needed to be set? And some states are trying to encourage, require, I think they're trying to figure it out to get plans to pay certain providers higher rates, like some of the behavioral onesie twosie shops that they're worried are going to go out of business. If the plans have to pay those higher rates when they were not built into the base rates, it can destabilize the insurance industry. So while we are very supportive of wanting to protect the providers, especially the smaller providers, we have to make sure that the health plans themselves remain solvent.
So does this, in sort of plainer English, mean we're going to see massive Medicaid rate increases in 2021 because plans are taking on these additional costs in 2020? They're operating under rates that didn't anticipate this, and to achieve actuarial soundness, we're going to see big increases, and governors and legislatures will be coping with a ballooning Medicaid budget.
Well, we're concerned about that. We don't have a way to quantify it yet, but it is one of the reasons why we do support when COVID-4 happens, that we would like to see even further enhanced FMAP. Right now, the FMAP increase on the original Medicaid populations was a 6.2% bump up. We'd like to see, I think that there's talk about a 12%. And as well as for those states that did not do the Medicaid expansion, I think there's still 14 of them left, including Texas and Florida. So we would like them to be able to get 100% match if they took up the expansion. As a way to encourage them to do that, which certainly with the 100%, that would insulate the states from having to pay for those populations. But so yes, we are concerned what's going to happen with rates in 21. Excuse me. But we hope that the Congress will help, at least on the Medicaid side, with the provisions that I mentioned.
Now, of course, there's the Republicans, are reluctant to do much to help the ACA along. So is that going to be a tougher political fight, trying to get risk corridors and reinsurance in the marketplace plans? I'm just wondering where you think the friction in the politics is going to be.
Well, we've certainly already seen with the administration this friction play out in a way that's extremely disappointing. With the Obamacare marketplaces, as you know, open enrollment typically takes place in the fall, so it's over, and there are certain qualifying events that allow what's known as a SEP, special enrollment period, that allow people to come in. And one of those is losing your health insurance because you lose your job, which is obviously happening to a lot of people. And those people can then enter the marketplaces. And if their income has decreased, they can get subsidies, which is great. But there's a lot of people who never had health insurance to begin with, who cannot enter the Obamacare marketplaces. And it appears that the reason the administration is not allowing a special enrollment period, unlike how they did it for hurricanes in the past, that is because it's tied up in the Texas VA's court case, and that they don't want to acknowledge the importance of Obamacare and the marketplaces to the health system. So we are profoundly disappointed that they made this decision, and surprised. It's an easy fix. 11 states have already, where they run their own marketplaces, have already opened for special enrollment periods, including here in Maryland, where I live, and 10,000 people have walked in the door for that, which is a great relief to those people that they have that available. But for the people, I think almost 3/4 of the states, I have 38 in my head, I think that's right, states are running Obamacare marketplaces via the Fed. So the Feds control that special enrollment period. And so we hope at some point cooler heads will prevail on this, whether in the administration or in the Congress. So I hope, and I know that there is a movement to try and push that from the congressional side. So we'll see how it plays out. But that's just such an easy thing for the Feds to do, to open that door so more people can walk through.
Just to be extra clear on this, people who were covered by their employer's plan, who are laid off as a result of COVID, the current structure of the ACA, this is a qualifying event, and those people will be able to buy coverage on the ACA exchanges, correct? And as you said, presumably their incomes will drop pretty significantly, and therefore they'll get subsidies, which will at least bring the coverage into some sort of approximation of being affordable. I'm just wondering whether, we're all aware of maybe the massive unemployment that's going to occur, whether we can be a little bit less worried, because the law, without any sort of action by the administration or by the Congress, will allow these people to go to the ACA exchanges and get coverage.
Mm-hmm. Well, it certainly is good. It's a good feature of Obamacare that they have this. There's other qualifying events like having a baby, getting divorced, things that change your circumstances. But there are lots of uninsured people out there. We know there were 28 million uninsured people a month ago, and we think that that's going to increase significantly. Could be up to 40 million people uninsured going forward. Many of these people who are newly uninsured were low-wage workers that typically didn't have coverage. All those Uber drivers and people who work in the grocery stores if they're non-unionized, and the construction workers and the retail workers, a lot of them didn't have health insurance. So there's a big group of people that the current special enrollment period will not help. Now, that being said, also for Medicaid, that our door is always open at Medicaid. So unlike the marketplace, where there's a specific time, and there are premiums that are imposed, even if with the subsidies, they can get pretty low. For people whose income has dropped even further, for I think a family of 4, I want to say below 12,000. I wrote it down and now I'm forgetting the number. But they can always come into Medicaid at any time. And when you go to healthcare.gov, you put in your state, you put in your income, and it will push you either to Medicaid or to the marketplace, depending on what you think your monthly income is and also your annual income. So for a lot of people, if their income is completely gone and they didn't have that much income in the first 3 months to begin with, they will probably qualify for Medicaid.
So there will be coverage for, would you say a large percentage of people who are losing their jobs? I mean, do you have a general sense of the proportion? Because it seems like we have 2 fairly large buckets here: the people who qualify because it's an event, and also Medicaid, that those systems are in place to provide coverage.
Well, I can give you some flavor of that. HMA just did a really great analysis looking at what they think the impacts on the various health programs will be. Mm-hmm. And they estimated that at the highest rate of unemployment, which I think is like 23 million people being unemployed. We know we're at 10, right, this week. So, but they estimate that you could see a drop in employer-sponsored insurance of 35 million. So wow. A big number of people. At the same time, they estimated, again, kind of worst scenario, but unfortunately not unlikely, you could see 23 million people get on Medicaid. So that leaves another, 13 million people, and they're only thinking maybe 2 to 3 million would get on the qualified health plan. So that just gives you kind of an order of magnitude. I can't answer this explicitly, but just kind of doing some quick calculation here, there's a lot of people that will be not able to get into the marketplaces because of this decision on the administration's part.
So just at the level of operations and logistics, are your members sort of having to add people? I mean, just it seems like they all of a sudden might have a huge influx of members, and I don't know whether it's also going to change maybe some issues in terms of networks, whether you're going to need, what's coverage unless you have access to a provider. So
Mhm.
it just seems like you might be dealing with a it seems like you might be dealing with a deluge into your plans.
Right, and we are talking with our plans about how they're preparing for it, what we can do to help them. But yeah, if Medicaid is now at 80 million people, we could be close to 100. So significant impact, probably differing by different states, whether there was an expansion done. Again, in Texas and Florida, no expansion. So so the things that our plans are concerned about is what does it do to their reserves if they suddenly take on all these people, and it could be in a very short time period, and their reserve levels are based on their premiums. So as they collect more premiums, they have to put aside more money, and will they be able to keep up with that? That's an issue. We also worry about network adequacy, bringing on all these other people when a lot of their providers are being shut down. Will they have the network adequacy that they need? So those are two big things for our plans, and our plans, of course, are very concerned about the financial stability of the hospitals and the community health centers and the providers. One of the things that the administration has said is because they won't do the special enrollment period, and they're not really pushing Medicaid, is that they've said, well, we'll give I think they said $30 billion out to providers to care for the uninsured people who are uninsured and have COVID, which is great. And I think that money will be well spent on those people. But there's a lot of uninsured people that don't have COVID and who've lost their health insurance or never had it to begin with. So one of the things that we are concerned about is how that money will be distributed. When they sent the money out to just recently, yesterday, I think it was 30 million. They sent it out to providers in Medicare Advantage who were in the Medicare fee-for-service providers. But we know that only about right now, 30% of people in Medicare are enrolled in Medicare Advantage plans.
Right.
And there are lots of docs who primarily are taking managed care and not fee-for-service anymore. So we are very concerned on the Medicare side. Well, docs that are seeing hospitals that are seeing a lot of people through Medicaid managed care, are they going to get that money? We know that children's hospitals don't see a lot of Medicare patients and pediatricians, that kind of thing. So the administration said they understand that they're going to get money out to the Medicaid providers, which is great. But we are concerned that because in Medicaid, 70% of the beneficiaries are in Medicaid managed care versus fee-for-service, we don't want the money going out only to providers that see fee-for-service, because they're not going to catch a lot of the providers that are in managed care. So we are bringing that up to the administration and to our colleagues at the associations of the provider groups to make sure that however they get the money out to the Medicaid providers, and that's much more complicated because the federal government doesn't have a direct link because of the 56 Medicaid programs, that they take that issue into account.
The money that would go to your members or to insurers is not flowing as sort of a direct out of the stimulus, right? It would be a question of allowing rates to go up in next year. We're not contemplating money going directly to your members or any other sorts of insurers, are we?
Not directly as health insurers. Many of our plans are eligible for some of the loan and the payroll protection plan,
Right.
Because they're nonprofits and they have under 500 FTEs. I have not heard that any of our plans are applying for it, but that would be one thing if they felt they needed it. I have not heard that yet, and yeah. So I think that the issue is more the rates for next year. How are they set? based on either continuing treatment issues or whether the Medicaid loss ratios in this year are much higher. Health plans, particularly Medicaid health plans, but even the commercial health plans don't have very high margins. Our guys typically have 1% to 2% profit margins. Commercial plans a little bit higher, but so there's not a ton of room for being able to absorb these types of costs, especially if it goes on for 18 months, which could take us over 2 rate cycles.
So there is one scenario, isn't there, where I guess it would depend on where the health plan is, but where actually their medical expenditure might go down because I understand that some of this service is being postponed, but some of it might not happen at all. People decide, if they're on the borderline in terms of getting their knee replaced, the surgery gets canceled, and maybe they muddle on through for another while. And we're reading stories about hospitals laying off people, and I think providers are concerned about the root. I don't want to call it routine because that's the wrong, but ordinary or the regular provision of medical service diminishing as a result, not so much of COVID, but of the social distancing and the mitigation efforts. So as you think about this, it seems like on the one hand, your members might be hit with huge COVID costs. On the other hand, maybe they're going to be spending less on a lot of other things.
Yeah, I think really the jury's out, and we'll have to we're telling our plans you need to document everything, try to get providers to document everything. Even with the social distancing, we know with the telemedicine, there's lots of phone calls being made and video conferences. So there is some of that is still going on, although it's the elective surgeries in the hospital that are being stopped. So we have to just wait and see.
Right. Right. So have your members as employers laid off people, or is it the sort of work that by and large, is office-based work and can be done, remotely or or through Zoom?
Right. Yeah, for the most part, they've all gone to telework. I've only heard of one health plan laying people off, and that's at Boston Medical Center, which is very tightly tied to the hospital. And I think it was because of that tight relationship with the hospital. But besides that, we haven't heard of anything.
So we've discussed a lot of things. Anything that I'm missing in terms of how you see this affecting your members, or maybe we're actually losing sight of the people involved? And I think we know that COVID is hitting people with comorbidity hard. The deaths are disproportionately affecting African Americans. I am not sure, as I speak now, whether the epi shows so far that it's disproportionately affecting low-income people. But do you see it hitting your population, the people that you're helping with your coverage, disproportionately?
Well, we certainly are worried about what we're reading about the African American population, and we'll be looking to see those reports as states start to be able to quantify that. One area we are very concerned about is people who bought what we call junk insurance, which other people call short-term limited duration plans. There was a kind of now infamous example over a month ago, 6 weeks ago, about a man who came back from China, went to Miami, thought he had COVID, so appropriately went to get tested in the hospital. Because he had a short-term limited duration plan, the plan basically tried to say, we don't, you had a pre-existing condition, what he turned out to have the flu, but they were trying to challenge paying that. And because of the publicity it got, I think that they backtracked, but there are a lot of people who are going to learn, unfortunately, the limitations of these short-term limited plans, whether they have COVID or not. But they typically don't include drugs. They have annual lifetime limits. Of course, we don't like them to begin with because they set rates based on your pre-existing condition and whether you're female or not. But unfortunately, I think a lot of people are going to learn the hard way why we call them junk insurance. And we have actually sued the federal government to undo a regulation which allows people to buy these for up to a year and then additionally renew them for up to 3 years. So the House bill that ultimately became COVID-3 did include a provision to roll back the regulation. So we'd also like to see that. But I think that's another thing we're very concerned about is just what is the impact of these short-term limited plans on coverage. People think they have coverage until they get sick. So.
That made me think of something else that I've read about. I think it was Larry Levitt at the Kaiser Family Foundation who mentioned this in something I read. Whereas the generosity of waiving the out-of-pocket costs for COVID testing and then treatment is great. But is there going to be is there a problem that I, in good faith, think that I'm maybe have COVID? I get care, but it turns out I don't, and I will see that cost sharing to its full extent because, as it turns out, I didn't have COVID. And it also, it raises the issue of whether some people might be hanging back and seeking testing or care because they know that they're going to be exposed to cost.
Yeah, I think that is a concern that these provisions are only for things related to COVID treatment, but there's a lot of people out there that are getting sick for other reasons, or as you said, think they have COVID, but it turns out to be the flu or pneumonia, or they break their leg or their cancer treatment. So I think that as other people have said, that this is really exposing the weaknesses of our current system. And while there's probably a place for copays, but certainly the high deductibles that we see in both employer sponsored and self-insured, as well as the marketplace, can be very difficult for people. And it's certainly something that I think when this is all over, and someday it will be, I'm hoping that we'll take a step back and say, really, what should our both health and social support system look like to prevent this kind of thing from, you may not be able to prevent a pandemic, but you can prevent some of the these ancillary problems that it's causing.
Does this make this experience with COVID-19, in your opinion, make a stronger case for either a public option or Medicare for all?
Well, we've all along said that the real goal is coverage for everybody, and there's multiple ways to do it. We think obviously health plans are a better way to do it because you get someone looking across the whole person, doing care management and that kind of thing. So we would continue to advocate, as we have strongly, for universal coverage, whether it's through Medicare Advantage for all or Medicaid for all or public option. We want to see that everybody has coverage in this country.
Good. So, how are you doing? Do you know anybody who's sick with COVID-19? And I assume you're okay.
Mm-hmm. Yeah, well, thank you for asking. It's funny, I ask people that all the time too. And in what I call my inner circle, so far, no one has been directly affected, but the outer circle is starting to fill in. So it definitely feels like it's coming closer. And I have 2 teenage sons that are doing teleschool. One is actually still working at a garden store, but he wears his mask every day. And so, we're definitely seeing how this has played out for young people, and definitely also seeing the digital divide for children like mine that have computers at home and strong Wi-Fi and can do teleschool right away. They're going to be fine. But for kids that don't have that, it must be just terrible to see the kids falling further and further behind.
Yeah, I think crisis is a big reveal. Mm-hmm. And we are sort of seeing some features of our healthcare system and our society in sort of sharper relief as a result of COVID. Mm-hmm. That's not great, but maybe if there's some action that happens as a result of this, there's, if not a silver lining, some sort of long-term benefit.
Right.
So,
Well, yeah, it turns out it really does matter how our neighbors are insured and what they have access to, because it ultimately impacts us all. So.
Indeed. Well, I think I think we've covered a lot of ground here. It was a pleasure to meet you on Zoom.
Yes, thank you very much. And
You seem like a Zoom pro to me, not an amateur. I think you've done many interviews in your day, so appreciate the time, and thanks. Stay home and stay safe.
okay, all right. Thank you, Peter. Bye-bye.
Thank you, Peter. And don't forget to check out the websites of these MJH Life Sciences brands and more to get additional information across the medical field.